Dear ladies and gentlemen, dear colleagues, I thank you very much, Manos and Manos, for the kind invitation to speak to you tonight about the difference between metal-backed and all-poly glenoid implants for total shoulder arthroplasty. First, we should start from the anatomy of the shoulder and the anatomy of the glenoid that is highly variable. The articular surface is often described as pear-shaped, however, in 29% are ovoid in its shape. The width range from 20 to 35, and the height range from 29 to 50. Regarding the glenoid implant design, the design that includes the shape that can be anatomic or oval, the articular conformity, the method of fixation. It can be cemented, cementless, keeled, or pegged. And the material composition, it can be metal-backed or done only by polyethilene. More recently, we have seen the hybrid glenoid coming out in the market. Thus, we have two different philosophies in glenoid implant. The metal-backed ones, they permit, with porous material, a cementless fixation. These implants are commonly related to higher stress concentrations. And all polyethylene implants. These components usually require a cemented fixation. These implants are commonly related to lower stress concentration. What is the mechanism of failure of glenoid implants? You should be aware of this rocking horse phenomenon. So the stress loading the edge of the implant that determines a compression in one side of the glenoid and distraction in the other. This micromotion or rocking causes a breakdown at the bone implant interface with the final loosening of the implant. The mechanism of failure of the all polyethylene glenoid components has been studied by Roger Emery and Andrew Amis. With this elegant study, they observed the failure at the implant cement interface. In all design types, failure begins at the inferior edge of the glenoid, propagating superiorly across the back of the glenoid. The keel implants, they show a progressive propagation around the keel. In the pegged implants, the crack propagated as far as the tip of the inferior peg and then jumped across the bone to the tip of the next peg, where failure progressed at the cement bone interface. Different is the mechanism of failure for the metal back components. We have some critical aspects. We can have stress shielding of the underlying bone that potentially lead to osteolysis and glenoid loosening. We have a stiffness in the metal back prosthesis that can contribute to an accelerated wear of the polyethylene, because the polyethylene in these particular implants is thinner than in all polyethylene implants. And this can lead to a true polyethylene disease, with constitution of an inflammatory granuloma and the secondary glenoid loosening. The interface between metal and the polyethylene is a critical stress point. Thus, the failure of metal back glenoid components is related to the wear of the polyethylene insert. The second failure for this implant is rotator cuff in total shoulder, because that's another weak point of these implants, but this is not related to the topic we are discussing. So what about the mini battle, the comparison about these two systems in total shoulder arthroplasty? We have to look to study more recent study, because things are changing very quickly. That's a study of Tony Romeo and Patrick Denard, with a minimum 5 years outcome comparing the pegged glenoid with a killed glenoid, with a mean follow-up of 79 months. So it's quite a medium-term follow-up that is pretty good. And radiographically, they showed glenoid loosening in 33% of the killed glenoid and 25% of the pegged glenoids. So at minimum 5 years follow-up, the postoperative loosening from a radiological point of view was common, and there was no statistically significant difference in loosening between pegged and killed component. A radiographic glenoid loosening of all polyethylene components was associated with decreased functional outcomes of the patient. The rate of loosening thus remains a concern with both types of components. Then we can take advantage of a systematic review published last year with a total of 1,186 articles screened. So they finally found a rate of radiolucent line in 27% of PEG glenoid and 17% of metal bag glenoid. The loosening rate was 15% for PEG glenoid and 5% for metal bag glenoid, and the failure rate 6% for PEG glenoid and 2% for metal bag glenoid. In the subgroup analysis of a shorter follow-up, the lower rates of radiolucency and loosening was in the cemented PEG group, with no difference in failure rate. But in the longer-term follow-up, metal bag glenoid was better in terms of loosening and failure rates. They concluded that the modern metal bag glenoid component seems to be a promising alternative to cemented bags glenoid, and that all polyethylene glenoids tend to increase loosening and failure over time. What about the new trends that we can face? So one interesting paper is the one of Richard Friedman and Chris Roche that is about the cage glenoid compared to the cemented polyethylene glenoid. They extract 632 primary anatomic total shoulder from a multicentric study with 316 patients with hybrid cage glenoids and 316 with all polyethylene cemented glenoid. The results were that cage glenoid patients had significantly lower rates of radiolucent lines and radiolucent humeral lines than all polyethylene PEG glenoid. In the all polyethylene PEG cohort, they found 12 cases of aseptic loosening that account for 3.8%. In the cage glenoid, the rate was 2.5, much less. So in conclusion of this elegant study, at 50 months mean follow-up, the cage glenoids demonstrate equally good clinical outcomes to the all polyethylene, so the classic that we have. But the cage glenoids had significantly fewer radiolucent lines around both the glenoid and humeral components and a lower revision rate. Even my friends, Mr. Brilakis and Mr. Antonogiannakis, they did a nice study, a nice systematic review to determine the revision and complication rates of hybrid glenoid components for aseptic loosening in total shoulder, and they showed the survival rate of hybrid glenoid at 97.4%. So, the total shoulder arthroplasty with hybrid fixation glenoids has a higher survivorship and low rate of glenoid component-related complication at 4 years mean follow-up, and the short to mid-term outcome of total shoulder using hybrid glenoid component is not inferior to the outcome of cemented or polyethylene glenoid components. So do we have any advantage in revision surgery for total shoulder with metal back glenoid? So we know that loosening of the glenoid component represents 12.4% of all complication and is much more frequent in anatomical total shoulder than in reverse shoulder arthroplasty. But reverse shoulder arthroplasty is always metal backed. And we know that we have even very good results with revision of total shoulder arthroplasty to reverse shoulder arthroplasty. So the revision shoulder arthroplasty, the reverse revision shoulder arthroplasty is a valid option in failure arthroplasty, reduce pain, improve function, and positively affects patient quality of life. We know that metal back modular implants finally are easier to revise with the reverse. So this makes sense to use a modular component, metal backed, in the total shoulder arthroplasty, because in case of need for revision, then we can more easily convert from total shoulder to reverse without having to revise the glenoid component. Just a case of that. This was one of my first total shoulder arthroplasty, was performed in 2001. In 2014, this nice lady came back to me and said, "Oh, I'm sorry, your prosthesis is not working anymore. Can you change it? Can you do the job again?" And due to the fact that I used in the first implant this metal back glenoid component, it was easy to transform in a reverse with a very happy patient again. Just remember, if you use this modular system, to use a glenoid inclination suitable for a reverse shoulder arthroplasty transformation with a slightly inferiorly tilted glenoid. In conclusion, not all glenoids are the same. Gilles showed us that we have a huge scenario of glenoids from type A to type C. And so the personalization is required in the glenoid. Do you agree with me? That we go from standard implantation to eccentric reaming to glenoid bone grafting. We use glenoid augmentation as well. Because personalized medicine is very important. It's a type of medical care in which treatment is customized for an individual patient. Perhaps Hippocrates already stated about this idea with the famous sentence, "It is more important to know what sort of a person has a disease than to know what sort of disease a person has." And so we need to personalize our total shoulder. In such a case, like a young, active man with a very good calf, I use a modular system that allows me to do an almost easy revision in case. In a 75-year-old, retired and quite nice lady with a very good calf as well, I prefer to use a cemented glenoid with a mini stem to reduce the invasiveness of my implant. So the take-home message, always consider the kind of patient you are operating. Always consider the anatomy of the patient. Be able to manage both all poly and metal-backed glenoids. Look with interest at hybrid glenoids and always consider the possibility of future surgery when choosing the type of glenoid to implant. I thank you very much for your attention.
Well, thank you, Pietro. A very nice presentation. And we are going to proceed now with Professor Giuseppe Porcellini, and then we are going to have we can have a discussion and answer questions. And Manos.
Before Giuseppe's presentation, we experience sometimes in live events some problems, and technology is not always helpful. So I'm sorry about the inconvenience. I would like to welcome everyone in this e-series, the mini battles by Athens Shoulder Course. I'm Manos Brilakis, and Dr. Antonogiannakis is here with us to present this episode. In this episode, we have Alexandre Laedermann, the boss of the event, with us in order to do a very interesting discussion. We hear the presentation of Professor Pietro Randelli, who is a full professor in orthopedics and traumatology at the University of Milano and past president of Sigascot. And now we will wait for the presentation of Professor Giuseppe Porcellini, which is associate professor at the Unimore University of Italy and the Sesec assistant editor of Shoulder and Elbow Surgery Journal. So our subject today is the total the anatomic total shoulder arthroplasty, and we are ready to hear you, Giuseppe, with very curiosity.
Thank you, Manos. I try to connect with my.
But I think Manos will have a question and a poll.
Yes. Until Giuseppe is ready, we can have the first poll question, which is from the total number of shoulder arthroplasties you perform per year, which is the percentage that refers to the anatomic total shoulder arthroplasties. So please take your time and give us your answer. The option is less than 10%, less than 50%, and over the 50% of the cases.
Okay, Manos, did you see the or not?
Unfortunately, I can see your presentation. It's not a day-to-day, but we will be...
It's okay now?
No.
Oh, Giuseppe.
I try a lot.
So, waiting for Giuseppe's presentation, Pietro, which is your preference? What prosthesis do you use?
The percentage of total shoulder replacement compared to reverse is 2 to 8. So on 10 prostheses, 2 are total shoulder and 8 are reverse prostheses. And as I showed in the presentation, if I have some people, young, active, I prefer a metal back that I can change and switch to a reverse finally. And if I have, old people, 70, 75, retired people with a really low, use of the shoulder, then I prefer to do a cemented glenoid with a mini stem, like with the SN Flex of Tournier.
Manos is okay now?
We see it for a minute, but we lost it again. And Pietro, between the metal back and the all polish that you perform, and I see you have a great company with you. What's the percentage?
Yeah, it's almost most of them. They are fully cemented glenoid, because most of the people, they are older than 70. And I can say 70% are full cemented glenoid, all poly, and 30% they are metal backed.
Okay. I think we are lucky and ready to see your presentation, Giuseppe.
It's okay now?
Yes, it's okay. It's okay.
Finally. Okay.
We are ready to hear you whenever you are ready. Please proceed.
Sorry, but there's another problem. Pietro, è un casino qua.
Okay, don't worry. Keep trying, Giuseppe. There's no problem. We can wait it. Pietro.
Sorry, but
No problem. Don't be anxious. It happens.
it's okay now?
Unfortunately, not.
Because I open PowerPoint, but
Pietro, how much inclination do you prefer to give in this metal back component?
But usually the inclination I prefer is with a slight inferior tilt, and that's very important, because you avoid to have shear forces if you use an inclination. If you don't use inclination, that you can increase the rocky horse effect, because the humeral head is pushing on the proximal and on the distal part of the glenoid. So I suggest always to use and to have just a little inferior tilt. What do? You, Manos and Alexandre, what you do when you do a total shoulder replacement?
Alexandre, please.
So of course, I do preoperatively a CT scan to determine if I have bone loss or not, and if I think that the bone is okay for an anatomic, I try to preserve as much as possible the subchondral bone. So I'm not going to ream in order to have some inferior tilt or things like this. Because I want to have a very strong bone, so I just use a curette and then a very slight trimming, and I put my polyethylene. Actually, I do not use metal back, but as you said, we need to continue to follow a patient, because the preliminary result of the new design are quite good, even if we know that in the past it has been disasters.
So you use all poly implants for the anatomic, for the glenoid side.
Yes, correct, sir. And following the study of Patrick Donard, I moved from a keel glenoid, and I think that this is a question that has been sent. So Ilias Solis asked if the higher losing weight of the keel component offset by the perhaps easier revision at his leave a better managed bone defect in the glenoid, meaning if you have a keel glenoid, you should have postoperatively a central defect. if you use pegs and you have to remove everything and everything has moved during several years, you will have a larger defect. So at the beginning, I prefer kit glenoid, but with the pegs, the shorter the result of the pegs, I moved to peg implants because it's faster. You have a very good primary fixation. So as soon as I cement my polyethylene with pegs, I can move to the humerus. With kilt, I'm afraid, and I put pressure during 12 minutes. So it's easier, it's faster for me, and the primary stability seems to be better with pegs. That's why I moved to pegs now.
I agree with you that pegs, they give better primary stability, Alexander. But unfortunately, I had the same sensation that you can speed up the procedure just, going immediately on the humerus. Unfortunately, when I did that, then I have more radiolucence line on the glenoid. What about you? So I keep 12 minutes the compression of the polyethylene because I do not feel comfortable. I had too much radiolucent line if I switch immediately to the humerus.
I did not observe it yet, Pietro, but I will have a look clearly since I know that.
And what is the percentage, Alexander, of anatomic to reverse in your practice?
Please unmute, Alexandre.
Excuse me, this is something that did not happen during the first 8 years of my careers, and then I wouldn't say that I had a series, but I revise, I change 3 anatomic, I convert 3 anatomic into reverse during the last 3 years. So this is not so frequent. I didn't observe catastrophic failure with my polyethylene, my killed polyethylene yet, but I had some rotator cuff failure and so 1 rotator cuff failure and 2 glenoid loosening that I convert, and this is quite easy actually. I just use, if it's a central defect, I just use dry bone graft. I put a screw base plate and usually keep the stem. So this is fast surgeries. I agree with Pietro. I mean, this is not a big deal to convert usually an anatomic into a reverse if you don't have an unbelievable humeral stem, very difficult to remove. It can be a fast surgery.
Well, I use the Lima anatomic also, and what I observed was that most of the failures of the prosthesis were not due to loosening of the glenoid, but it was due to loosening to failure of the cuff, and that was then it was very easy to convert to from anatomic to reverse by just changing the glenosphere, implanting the glenosphere in the metal base already implanted, and also due to the fact that it is inlay, the stem of the reverse, it was easy to reduce the new prosthesis, because when I tried to convert anatomic to reverse and had a non-lay reverse, it was practically impossible for me to convert it from anatomic to reverse. I had to revise the stem also.
Pietro, when you do when you implant a primary anatomic prosthesis, so you put your polyethylene slightly lower on the glenoid and with an inferior tilt already.
Yes, Alexander. I appreciate what you explained us about your surgical technique. technique that is very good. I mean, just to remove slightly the cartilage, to rely on the subchondral bone. This is very good because it's a tough bone and it's not a problem. But if you see, you know, the mechanical forces that they go across the joint, then if you imagine to having a slight tilt, then you have a compression of the humeral head against the glenoid that is in contrast with the rocky horse effect. So you really reduce the shearing forces, and that's why I prefer to have a slight tilt. Of course, you don't have to violate to match the subchondral bone and to go in the cancellous bone, otherwise you can have a loosening for sure. But I prefer, when possible, to have a 5-10 degrees of an inferior tilt. Just to, you know, to have the forces going across the joint really in a very good way.
Because you don't care, because you don't have problem of glenoid loosening with metal back, at least with your design. This is why.
I mean, it's not the everyday practice. The everyday practice, but it is different from the literature. I agree with Manos that my everyday practice is that they fail because of the rotator cuff failure. So I revise most of these people because the rotator cuff finally, you know, is destroyed. Is really at the end of the life. Very few cases I have to revise because of the glenoid metal back failure. So this is an everyday life for all poly. All poly, they fail the glenoid, and in some cases they fail the cuff as well. So we have two different kind of scenarios. I can say that's why if I have a very active young guy, I prefer to do a metal back glenoid, because then I will do a more simple revision. Sometimes it's not so simple. It's not that when you use metal back, then you can switch very easily. Sometimes it's a tragedy. It's very tough sometimes. But in other cases, it's easy. You just convert, you change, you put a glenosphere, you put a modular inlay part on the humerus, and that's it. And that's it.
Pietro, you mentioned the long-term, the mid-term glenoid loosening with the polyethylene. I remember one study of Luc Favard that found, I think it was 68% of glenoid loosening at 12 years. And a recent study that is accepted IMPRESS in the GSES from Evans at 20 years show 100% of glenoid loosening, meaning that all the poly at 20 years are loosed. And I agree that with metal back, probably that we won't have, if we find a good solution to fix the polyethylene to the metal back, we won't have this problem. But these bring another questions. And we talked before about reverse shoulder arthroplasty. We know that we have better and better results with the reverse. Long-term results are coming out and are quite good. So do you think that one day we will change completely from the anatomic to the reverse due to these very high rate of glenoid loosening?
That's a great question. You are really a smart man. Really, really. I like this question a lot because I did this question to myself several times, you know, because with reverse, you have always an assured result. But with total shoulder, you have a perfect shoulder. So when I have a total shoulder, then I'm very happy with the patient. The patient is happy, say, "Oh, yeah, I have my shoulder when I was 25 years old." With the reverse, this, at least in my hands, is not like that. With reverse, you have some lack of rotations. You have the patient, of course, free of pain, but we don't have the patient that says, "Oh, I feel the shoulder is the one that I had at 25 years old." I don't know if you have the same experience, Alexandre and Manos.
Yes, I was performing more anatomic. I start from hemi for arthritis. Then I passed to anatomic for arthritis. And then now I'm performing more and more reverse. And now I keep the anatomic for a young person who has a type A glenoid, and it's not deformed too much. And so it is the best patients for a reconstruction, the easiest cases, because the deformity is very small, is little, and the patients are young. And these patients I rehabilitate very slowly because I'm afraid I follow a deltopectoral approach and I do a subscapularis cut, and so I am waiting for the subscapularis to heal, so I rehabilitate the patient slower than when I do a reverse. But I have the impression that if we do a reverse prosthesis in this type of patients, they will also have a very good result. The bad result of the reverse, as far as the rotation and all this, I think it is because we are performing reverse for a more deformed and more severe arthritis than we do now an anatomic. And it's not the type of the prosthesis. This is my impression. I can't prove it, but I have this impression. I have patients that they have perfect range of motion, perfect strength, and perfect function with a reverse prosthesis. And I think it's not that it is a type of prosthesis, it's something else that it's making the difference in the range of motion.
Pietro, you know, I asked myself, like you did some years ago, if maybe Paul Gramont was right again, because I don't know if you know, but in Dijon, nobody saw something else than a reverse since 40 years. Okay, the anatomic total shoulder arthroplasty in Dijon does not exist. And I contact Gramont's team to know if they had like results that could allow me to have a better background for an ethical committee, and they had to admit that they did not follow their patient, so they don't know in Dijon. So we will have to do it for them, unfortunately, but they did not report catastrophic or awful disaster, however. So I'm like you, just wondering, and I think that we need to follow a patient. But of course, that if you implant an anatomic in a 55 years old patient, you are probably sure that at the age of 70, 80, you will have to change it. If the patient is still active, I mean, because we know that the function decreases progressively. So this is an open question. I agree with you. A good reverse will never do as well as a good anatomic, but maybe that in the long term, the curve will change.
Okay. We have a question from Karen Bilsel. Which type of loosening will be miserable or defected after loosening of metal back or on polyethylene glenoid?
Sorry, I didn't catch the question. Can you repeat, Manos, please?
Yes, of course. Which type of loosening will be miserable or defective after metal back or polyglenoid? Excuse me. Giuseppe, don't worry about your presentation. Please take part of the discussion. It's very important if you want to be here with us. And unmute, please. I can hear you. Okay.
I think that Giuseppe is in big troubles tonight.
I think so.
So just answering your really tough question. My worst case where I was not able to do a revision surgery, they were after a massive osteolysis for a all poly cemented glenoid failure. And this happens sometimes because, you know, these people after 10 years, 12 years, they start having pain in the shoulder. They go to maybe to be visited by a standard orthopedic surgeon that says, oh, you need some physical therapy, some anti-inflammatory drugs. And these people, when they feel pain, it means they have a reaction, they have a polyethylene disease, you know? They have granulomas, they have a bone reabsorption. And then a couple of years, they pass very, very quickly, and all the bone of the glenoid is destroyed. And in some of these cases, I was not able to do a bone graft and to do a revision surgery. So I just put, you know, a big head on the humerus and leave it like that. So my nightmare is those cases. I never experienced that in the metal backed because when the metal back is failing, usually you have metallosis, you have a huge inflammation, you have people with pain, and they come to you in a stage that you can even have some bone, and you can even do a revision. At least in my experience, maybe it's a limited experience.
One question, Pietro. When you talk about the metal back of Lima had a problem in the Australian registry. Was it a previous design? Was it? I think it was an Anatomic as well for metal back, but it was a previous design. Everything has been changed. Is it why you are confident?
I have to admit my ignorance regarding the issue with the Australian register. So the limal metal back, I think, is the same since more than 10 years now, maybe 15. And now they have other kind with a bigger post and post covered with tantalum. So they have a new design, but I'm referring to the standard implant. And I don't know about this Australian problem.
Yes,
Maybe you can explain me more.
There was a problem with the Australian registry. The model that was in Australia had a problem with the connection of the polyethylene to the metal back. And the reason of failure, there were two reasons of failure. That was disengagement of the polyethylene from the metal back. And they changed this design and they stopped having this problem. It was the way the two were connected. They tried to, the main problem with metal back glenoid is overstuffing of the joint because you have a bigger implant. And in order to have a thicker polyethylene, the connection mechanism between the metal back and the glenoid and not have metallosis, they changed the connection mechanism. And this made easier for the polyethylene to disengage. This was one of the problems. And they have changed this.
I did not experience about this disengagement of the polyethylene. Of course, this can happen, and thank you for letting me know this. And regarding the overstuffing of the joint, I think that this is about a surgical technical problem. It's not because of the prosthesis. So I had some cases of overstuffing, and I feel I did the error, the technical error. I don't think this is related to the implant. Of course, the problem with metal backed is that the polyethylene sometimes is too thin. So this can be really the weak point of the metal back implant, in my experience.
What about you, Giuseppe?
Can you hear me?
Giuseppe, no problem, don't worry.
Yes,
join our discussion.
I try to summarize my presentation because I prepare for the discussion. I follow your discussion. I have 3 minutes to discuss my presentation or not.
You have as time as you want.
Thank you very much. I prepare biomechanical and my experience about the problem of to identify the plane of scapula and the plane of transverse plane. Of course, now we have a lot of software, but different software in a planning presentation, different accuracy probably. And in my region, Pietro talked about the problem of anatomical. In my region, Emilia-Romagna, now we have only 10% of implant in anatomical way. And in my presentation, I try to explain this reason. Probably is too difficult to reach the glenoid plane, the scapular plane, the difficult to identify the scapular neck, and the soft tissues balance is another problem, because everybody knows the B2, B3, C, but is not only problem of bone, but the problem of imbalance of soft tissues. So when you study the calf in CT on in MRI, of course we see the calf in continuity, but it's so difficult to image the function of the calf in 10 years. So in Italy, of course, I want to know the idea of Pietro. Is very easy to implant reverse, but now is increasing the middle age osteoarthritis, because in my region is increase CrossFit or fitness, and you create a lot of osteoarthritis in very young people. So the first question of your web seminar is biomechanical, is easy to reproduce. Of course, it is mandatory to know biomechanical plane, is surgical skill, experience, because sometimes it's difficult to create a soft tissues balance. So in my experience, Pietro and Manos Antonogiannakis spoke about metal back. In Lima, of course, Alexandre, there was a problem about the first generation of metal back. But the second problem in my practice is metallosis. In my experience, I have 3 cases. Unfortunately, I show in my presentation, but I want to explain very accurately. The patient has not pain, arrive in my office with a noise, with the crank, with the problem of the noise, because after 5 or 6 years, the problem of the calf, of course, you have not balance humeral head, and when I open in open way the joint is incredible black metallosis. So I don't like now to implant a metal back in anatomical way. Not only for like Manos spoke about increase the lateralization, but if you implant very well metal back, you have after 10 years or 50 years the metallosis without pain. And I have in one case the superior part of metal back completely destroyed and was impossible to insert a glenosphere like Pietro showed us because destroyed the superior part of metal back. So, which is the best biomechanical glenoid in anatomical, peg or keel? In my practice, I prefer the peg with the magic peg in without cement but with the bone in the center, not only for elastic reason, but if you revise this prosthesis, it's very easy to insert the metaglena because it's not so aggressive like a keel. I remove a lot of keel, and sometimes it's very difficult to implant metaglena without bone graft. So I recommend to implant anatomical in a very selective case, but around the world, I don't think is a good idea 90% of reverse because it's easy. It's not easy to revise a reverse. And so I think is a good topic for the discussion. So I try to summarize my topic because biomechanical is very interesting, probably with help of navigation of robotic in the future. We try to find with preoperative planning help the right point of insertion of metaglena and or anatomical, because I think in my work probably preoperative planning and navigation will be useful for anatomical, not for reverse, because for reverse now we have 2-3 tricks to avoid complication, but anatomical implant is only for all the surgeons, for the surgeon with a lot of experience to avoid rocking horse like Pietro described, or superior part of a rocking horse, or pain about loosening. Thank you. Sorry for my technical problem.
Giuseppe, when you use the magic peg, so you put bone around the magic peg, do you put cement around the other ones?
Yes.
Yes.
Yes, because I publish with my when I worked in Cattolica with Giovanni Merola my experience about the bone, the only of course cancellous bone in the center, and just small amount of cement in the inferior and superior peg. But if you have a good bone just around magic peg, you haven't loosened lines in inferior posterior inferior peg. My experience is exactly a direct proportional. If you have a good bone, good osseointegration of magic peg, you have not lucent line in the cemented posterior inferior peg. Is this clear, Alexander?
It's clear, sir.
Sorry.
Yes, but Giuseppe, are you telling us that you have an osseointegration of a peg, a polyethylene peg?
If you haven't osseointegration, you can have more osteolysis in posterior inferior peg. Is not loosening, but more radiolucent line. Probably you are more micromotion, and the first peg that moves is posterior inferior.
Yes, but
Okay.
so you have some cases where the central peg without cement is osteointegrated.
Yes,
The
yes.
polyethylene is osteointegrated.
We have two experiences in literature. Iannotti says not a good osseointegration. But in my experience, because it's different, I use a different company and different design. But I'm very, very, selected patient for anatomical. If I have some doubts about unbalance, horizontal or vertical, I don't implant the anatomical glenoid.
I think that we have very interesting questions coming, guys.
Yes, there are a question from Matthias Hoffman that asks about the different offset of the metal back of the polyethylene glenoids. How does it influence your planning?
But Manos is not important, not only the lateral position, because in metal back probably the reaming is more aggressive, because of course everybody of the faculty has experience, and if you have different thickness of the metaglena and the polyethylene, you have different tension of the cuff. So probably now I don't recommend metal back, not only for the metallosis or follow up for the cuff, but probably is not the right road for lateralization.
Okay. As the participants in the first poll answered that they do less than 50% of their practice of anatomic total surgeons, and the second poll question is, which is the preference for the glenoid implant? The old polyethylene component, the metal back component, or the hybrid component, and respectively, which is the preference for the humeral implant, stemless, stemmed, or short stem? And take your time and answer this question. And I would like to ask for your preference. Giuseppe.
I'm not very young. Probably Alexandre or you are a difficult experience, but I try. I implant after my fellowship in Columbia, in New York, with long stem. Then I try Copeland. Then I try stemless. But I think that is very, very difficult to implant a stemless. It's very, very difficult to have a good result with resurfacing. Now, for the humerus, I have my preference is mini stem, but mini stem I want to study in the future the curve or straight, or now there is a lot of study with the expert, of course, with the stem with metaphysis and diaphysis. So is best the right or curve? The problem is the stress shielding of tuberosity, of stress shielding of the cortical situation, with or without cement. So, and another question is retroversion. Is very, very difficult to arrive to original retroversion. And I tried, my preference in the human stem is mini stem, but probably now not in the gold standard, or it is necessary to have more research. From the glenoid side, I think that the solution now is polyethylene. Probably is a good idea hybrid, but is hybrid for probably to convert in reverse in the future. But I'm not sure is because in the past I had experience in hybrid of a company with tantalum and polyethylene. And in my experience, a good result, but sometimes you have a wake point through polyethylene and metallic hybrid peg. This is my experience.
So I think that this is the first time in the history that I completely agree with Giuseppe Porcellini. I use short stem, uncemented short stem for the humerus with an anatomic retroversion and cemented polyethylene on the glenoid.
Pietro, there's a question for you.
Yes, please.
From Kerem Brisel. When you consider to convert an anatomic to reverse prosthesis, do you always trust the previous metal back component? And how do you evaluate the stability of this component during the revision? Do you have a trick for this?
Very, very good question. First, I always try to use the metal back of the anatomic, and you see that most of the time it's really very stable. It is not stable only in case of failure for infection. In those cases, this is really easy to revise because you take out from the bone very easily, but then you have to do a two-staged revision. I don't do one-stage revision in shoulder, in total shoulder infected implant.
The participants also prefer the all-polyethylene component in 80%. Is the results of the second poll. So, do you want add something, Dr. Antonogiannakis or Alex?
I mean, they are reasonable.
Okay.
It was a tiring day.
Okay. So, I would like to thank to thank every one of you, Pietro Randelli, Giuseppe Porcellini, Alexandre Laedermann, to be here in this mini battle. I think we have some problems, but the discussion was very interesting. And thank everyone for attending, and thank you for being here. The next episode is in the next month is dedicated to tenosis of biceps, and we invite everyone to be there with this. And please, Alex, tell me what you want.
Thank you to my Greek and Italian colleagues. Thank you so much. It was a great discussion.
So,
Thank you, Manos. Thank you, Manos, and thank you, Alex. Was really nice to discuss and to learn. Really, all of us, we are enriched after tonight, and I hope to see you. I hope to see you in live very soon, my friends. Really, I miss all of you. Thank you so much.
thank you all for participating and for all these discussions, and I hope to meet live soon. Okay, good night.
Thank you. Please invite me, Pietro and Alex in Sartorini or in your wonderful island. We
are preparing
we are free.
We're preparing next Athens Other course for May. So it's going to be the best weather.
Bye-bye, guys.
We remind you that in order to earn the CME points, you have to fill a teeny questionnaire at the end of this episode. You can always follow our Facebook or LinkedIn page and stay in touch and follow BMed, because there are too many interesting webinars hosted in the forthcoming period. Thank you once again for attending, and have a nice night.